Dr. Rekha ma'am, are you there? Good morning, Dr. Rekha ma'am. Dr. Nandagopal. Dr. Sinnasamy sir. Dr. Subramanian sir.
மனநல மருத்துவர் டாக்டர் ஸ்ரீனிவாசன். மனநல மருத்துவர்னு சொல்றதை விட ஒரு சிறந்த பேச்சாளர்.
அப்படியா? எந்த மண்டபம் நீங்க இந்த இது பத்திரிக்கை வாங்கிட்டீங்க? எந்த மண்டபம்?
Good morning. Request all our members kindly text your name, email ID, TNMC registration number, and your mobile number in this chat box for our TNMC credit points. Welcome. Request all your kind attention. So every member kindly type your name, email ID, registration number, and mobile phone for our TNMC credit points. Welcome. Good morning, Nandu.
Good morning, sir.
Nandu. Welcome. Check Dr. Rekha ma'am joined. Rekha.
Sir, Jaraman sir, good morning. நீங்க பேசுறப்ப மத்த எல்லாத்தையும் மியூட் பண்ணிடலாம் சார். as a co-host நீங்க மியூட் பண்ணிக்கலாம். யார் பேசணும்னு நினைக்கிறீங்களோ அவங்கள மட்டும் நீங்க அலோ பண்ணிக்கலாம் சார்.
Okay, Arvind, please do that. Mute everybody except the speakers. Okay.
Sir, I will do one thing, sir. I will mute all, and yourself and speaker can unmute yourself, sir.
Oh, fine. Okay, good.
I will mute all now.
Okay. Thank you. Welcome, Dr. Welcome, Dr. Dhanamitran sir. Good morning.
Good morning, sir. Good morning, sir.
Namaste. Welcome, sir. Rajagopal sir, good morning. I request all our members kindly type your name, registration number, and email ID and mobile number for our TNMC credit points. I request all our members kindly, enroll your name, registration number for our TNMC credit points. There are 4 points. Welcome, Dr. Trivia Mohan sir. Welcome, sir. Good morning. Namaste, sir. Namaste.
Am I audible, sir?
Yes, sir. Yes, Sushila ma'am. Audible. Welcome, Yasoda ma'am.
Okay, thank you.
Good morning.
Good morning. Nice to see you.
Welcome. Nice.
Good morning.
First meeting of this academic year 2023.
Welcome. Hello.
Welcome, Saravanan sir, Vice President North Zone. Welcome. Good morning.
Yeah, good morning, sir.
Welcome, sir.
Best wishes for
Thank you very much, sir. Thank you, sir. All your blessings.
For the whole year.
And yeah, you can 100%, sir.
Your video is open.
Welcome, Dr. Inatia Tyagarajan, sir, our State Honorary Secretary, Dynamic Secretary of our IMA TNSB. We are all very proud to have you, sir. Welcome, sir.
Good morning,
Tyagarajan,
sir. Good morning, sir. Thank you for the invite.
Welcome, sir.
Welcome, sir. Welcome, sir.
Good morning, ma'am.
Sir, sharply we'll start the program at 11 o'clock. Dr. Bari sir is in Stanley alumni meeting. He may join in between. So Dr. Tyagarajan, sir, our State Honorary Secretary is there. So we'll start sharply 11 o'clock with a welcome address and a prayer and the chairman's address, followed by our state office bearers, Dr. Tyagarajan, sir, address.
What time are we starting, sir? 11?
Yes, sir. 10:30 to 11 introduction and login, sir. 11 o'clock sharply we'll start the program with a welcome note by Dr. M. Sushila, our member of our academic committee. Then prayer. Then we'll have a chairman's speech. Then we have Pari sir and you will give a talk. Then we'll start the CME program from 11:15, sir. I request all our members kindly text your name in the chat box, your name, registration number, email ID, and mobile number for the TNMC credit points. Welcome, Rekha ma'am.
Good morning, sir.
Good morning, Dr. Mangala Gauri ma'am. Welcome. Welcome, madam. Request all our delegates kindly mute except the speakers. Thank you. Today we have a wonderful speakers. They're going to talk about a very nice topic, common topic, very, very useful for all our members.
Good morning, Dr. Jairam.
Good morning. Welcome, sir. Good morning, sir.
Good morning.
Nandakumar sir, good morning. Welcome, welcome. How are you?
Good morning. Thank you so much. I'm fine.
Nice to be here. Thank you. Nice. Narmada ma'am, you want to share your screen? Just you can have some, you can start sharing screen. You can see your presentation. And I request Magesh sir also, you can start sharing your screen. I can see whether slides are very clear, visible, audible, and all.
You have to enable screen sharing, sir.
Mr. Aravind, please note Dr. Magesh sir is a speaker and Dr. Narmada ma'am is a speaker.
Okay, sir. Okay, sir.
Yeah, please unmute Magesh sir or Magesh Rajendran sir as well as Narmada ma'am.
Sir, Magesh sir is in unmute, please, sir.
Okay.
No, we have to enable participant screen sharing. The host has disabled.
Correct. Make him as a co-host.
Okay, sir.
Make Magesh sir as well as Narmada ma'am as a co-host.
Okay,
then only they can share their screen.
Yes, sir, I did, sir. I will...
Okay, fine. Arvind, kindly note, make Magesh sir and Narmada ma'am as a co-host.
Yes, sir. Yes, sir.
Okay. Okay, sir, your slide is visible, sir. Fine.
Fine, thank you, sir.
Thank you, sir. Narmada ma'am.
Yashoda ma'am, good morning. Rekha ma'am, good morning.
Good morning.
Morning, ma'am.
Nice to see you. Nice to hear your voice.
Thank you, ma'am. Thanks, thanks. ரொம்ப நாள் ஆச்சு மேம் உங்களை பார்த்து.
I know. We shall meet shortly.
Yeah, sure. Subramanian sir, good morning.
Good morning. How are you?
I'm
Good morning.
fine, sir.
Good morning,
Okay,
Subramanian sir. Good morning.
Yes,
Welcome, sir.
Yes, welcome, sir. So, good morning to everyone. Jayaraman sir.
Good morning, sir.
Good morning. Just in the chat box, whether members have to type all the details, including the mobile number,
Yes, sir.
if they want to have TNMC credit.
Yes, sir. I am typing, sir. Yes, sir.
Yes.
And also I am typing the account number for the online transaction of amount rupees 100 for certificate, sir.
Very good.
Welcome, Chinnasamy sir. Welcome. Dr. Jayaraman speaking. How are you, sir? Nice, sir.
Fine, sir. Good morning, sir.
Good morning. Welcome, sir. Welcome,
Good
Chinnasamy
morning.
sir. Chinnasamy sir, you are practicing in Bhavani Kumarapalayam, na?
Bhavani Kumarapalayam.
Okay. You are a physician practicing in geriatric or pediatric, sir? Or
Pediatrics.
Pediatric. Very nice. Okay, good.
I think we can set the guidance that you can mute as soon as they join.
Exactly, sir. Kind request
setting-
all the members mute your mic except the speakers. Kindly put your name, registration number, email ID, and the mobile number for the registration for the TNMC credit points. So those who want the credit points, online certificates, there is printed certificates. So we have to pay rupees 100 to this number, account number. Now I'm typing and send to you the number of account number. That is Indian Medical Association AMS. Account number 75260100001890. I will type. Please note that any queries you can call me later, or one of our academic committee member will help you, guide you to get the credit points from the TNMS.
Jairam sir, who is the admin for this program?
Admin for this program is Dr. Vijay Kumar, IT chairman, and his team, Ms. Prabha ma'am. And I have a local IT team coordinator, Mr. Aravind.
Fine.
Aravind is a technical person. He
Yes.
used to coordinate with me for all our IMA activities from Chennai,
Sure.
Villivak Minor branch IMA, sir.
Oh,
He is
okay,
the main host.
Okay.
Speakers and members, we are all co-hosts, sir.
Yeah, sure. He can mute, the
Yes,
unmute
sir.
and mute.
Already I mentioned, already told. Aravind, please note, mute all our mic except the speakers. Okay,
Okay,
Aravind?
sir. Yes, sir.
Thank you.
Once the meeting starts, I will unmute everyone. So the speaker and yourself can unmute yourself, sir.
No problem. Now itself we can unmute everybody. So those who wants to know, yeah, we'll do that. In another 5 minutes, we'll start the meeting. So before that, so we can all settle. Now I'm typing the TNMC credit point certificate, the details. Indian Medical Association AMS, account number 75260-10000-1890, Bank of Baroda. I'm typing the IFSC code, then I will post it in the chat box. Kindly note, and please do online transaction rupees 100 for this account for the TNMC credit points of 0.5. I will share my screen now. Aravind, can you see my screen? Aravind?
Yes, sir, I can see, sir.
Okay. We start in another 2 minutes. Aravind, kindly unmute first, the welcome note speaker, Dr. M. Susila ma'am.
Okay, sir.
Then Dr. Rekha ma'am.
Okay, sir.
Then me. Then Dr. Sendamal Pari sir, our president, and Dr. Enathiya Tyarajan sir, our secretary. Okay. Then Dr. Subramanian sir for the moderator of this program. Then speakers, Magesh sir and Narmada ma'am. Okay. This is the order of you have to unmute. Okay. Okay, Aravind?
Sir.
Yeah.
Hello? Hello?
Yes, ma'am.
Hello?
Yes, ma'am.
Yes.
Susila ma'am, welcome.
Waiting here, has sir come?
Yeah, we'll shortly start at 11 o'clock.
Okay, okay.
Already everybody is there. Our Honorary Secretary sir is here only.
Okay,
Our
sir.
state president is in the alumni meeting of Stanley Medical College. Sir is the chief guest. He may join in between. I request Rekha ma'am, please see in this our Parisar is there. Then we'll invite for the presidential speech, ma'am. Rekha ma'am. Okay.
Yes, sir.
Good morning. Yes, ma'am. So next to welcome note. So you have to give a prayer and see if Dr. Parisar as here or not. Sir is in the meeting in between. Join. If time permits, join outside. No issue. Okay, shall we start the program?
Yes.
Okay, welcome. I request our elite member, Dr. M. Susila ma'am, member of our academic committee and senior member of IMA Pundamal Herod branch, former deputy secretary, deputy director of our the Tamil Nadu services, medical services, to give the welcome note. Over to Dr. Susila ma'am.
Thank you, sir. Thank you. Good morning and greetings from the ever blooming academic committee of our Indian Medical Association, State Branch, Tamil Nadu. Welcome to all for this first virtual Zoom meet of the year. I am Dr. Sushila here, sir, member of academic committee and retired joint director of health of services, Government of Tamil Nadu. I'm very happy to be the first batsman of the event. Thank you, sir. I welcome our respected President of IMA State Branch. He is a most well-known, most eminent and senior member of our IMA, Dr. Sendamil Pari, sir. Welcome, sir. Following suit is our honorary secretary, our ever energetic 10E from Penny. Happens to be my hometown. Is Dr. Inatia Tyagarajan, sir. Welcome, sir, for this briny Zoom meet. Next follows our treasurer. Welcome, sir, Dr. VN Another Venkateshan, sir. He is hailing from our Tunganagaram, Jallikattu fame, Vadipatti, Madurai area. Welcome, sir, for your pomp area heritage. Our immediate past president, Dr. N. Palanisamy, sir, of Kowe. Welcome, sir, with due salutes. Following are our president-elect, Dr. Abul Hassan, sir, of Erode, where we joined him for the meet also. It was a very happy hospitality, welcoming area. Welcome, sir. And today's guest speakers, I welcome with a red carpet, our Dr. R. Magesh, the senior consultant and geriatrician, hailing from Apollo Hospitals of Chennai. Dr. Narmada, the senior consultant pediatrician of Nalam Hospital, Vellore, where I happened to grace the occasion of taking over of Satwachari Collectorate building by Dr. Mani Arasu, my husband, who was a deputy director of health there. Then, yes, welcome, madam, Narmada madam. Dr. Jayaraman, our always for welcoming academic chairman, committee chairman. Welcome, sir. And all the members of our academic committee, the delegates, members of our IMA Tamil Nadu State Branch. I welcome you to all to this prestigious academic committee meet, sir. I take this opportunity to have this with academic full zeal, showers of knowledge, academic skill sharing, and active participation which follows to come. I'm very happy to hand over to Dr. Rekha for the other session of the event. Thank you, sir. Thank you. Welcome.
Thank you, ma'am. Prayer by Dr. Rekha, ma'am.
Thank you, sir. Thank you. Welcome.
Thank you, sir. I may prayer, live to serve. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Physician's prayer, dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hand, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child, I rely on thee. Over to Dr. Jayaraman, our chairperson.
Thank you, Rekha, ma'am. Good morning. Welcome to all of you. Respected State President of our IMA TNSB, Dr. T. Chendamil Pari, sir. State Honorary State Secretary, Dr. N.R. Tyagarajan, sir. And immediate past President, Dr. N. Palaniswamy, sir. And President-elect of 2023, Dr. Abul Hassan, sir. And the State Treasurer, Dr. V.N. Alaga Venkatesan, sir. And all the senior leaders of our IMA. Today's guest speaker, Dr. Narmada ma'am, Dr. Magesh, sir. And all the senior faculties here and delegates, members of our IMA and members of our academic committee of our members of academic committee. So first of all, I thank you, Pari sir, for this wonderful responsibility as a chairman of this academic committee. You all know well, academic committee is an important committee to give an update of knowledge to all our practitioners. Knowledge is the power. So we have to periodically update. A lot of new things is coming in every field. So medical field also, we are getting new instrument. So telemedicine, robotic surgeries, a lot of advancements in the medical surgical management, computer-assisted surgeries. There are plenty of subspecialties. So geriatric, sleep medicine, somnology, and various fields. So we have to update our knowledges. Ultimately, we are helping the patients in the form of good care to our patients. So for this, we need to update our knowledge periodically. We must know all the recent advances, update of knowledge in each and every field, A to Z, from anesthesiology to cosmetic and every field. For that, this responsibility given by Dr. Pari sir. Last year also, Dr. Palaniswamy sir has given this responsibility as a chairman of academic committee. Last year, we did a good program of all the academic events covering from each and every topic. So our motto is to give good practical points to all our members to practice effectively. So this platform, academic committee platform, I thank our Vijay Kumar sir, IT chairman, for this wonderful Zoom portal for our members of our IMA TNSB. So thank you, our IT team, for this wonderful opportunity for creating this form. So you all know well, academic committee, we have a very good team of members to plan such a way that we are going to give a very good academic piece to all our practicing members, update of knowledges. We have a galaxy of speakers to present the very easily understandable manner. We can have the very quality speakers in our IMA. So we're going to give a very good program online and offline also through by CME and the symposium and panel discussions and all. So this is our program agenda. This month we have chosen the topic is clinical problems in extremes of age, geriatric and the pediatric perspective. I thank all the senior leaders and members of this IMA academic committee, and I request our state president Chendamil Pari sir, if your sir is here, sir is busy in the meeting of alumni of our Stanley Medical College. Sindhamil Parisar is chief guest of the day. So sir will join anytime. Rekha ma'am, please check sir is there. If sir is there, we can enroll to speak about this thing, presence address by Sindhamil Parisar. Otherwise, no issue. So sir will join at any time. So I thank Parisar for this kind of active, very powerful members to this academic committee. Dr. S. Rekha ma'am from Chennai and Dr. V. Nandagopal from Coimbatore is a pulmonologist. Dr. M. Sushila ma'am from IMA, Pundamil Herbal Branch, and Dr. N. Subramanian sir is the president of Tirunelveli IMA and senior consultant rheumatologist, professor working in a Velamal Medical College, Madurai, and is having own center in rheumatology center in Tirunelveli. And Dr. K. Venkatachalam sir from Kodambakam IMA is a very good academician, clinician. And we have Dr. N. Sudha Ramakrishnan ma'am from Trichy, physician. And we have Dr. M. Sinisam sir from the Bhavani Kumarapalayam. So we have wonderful galaxy of members helping to creating a very good knowledge to our members. So thank you, Parisar. Thank you all our members here. And with this few intro, may I request our Honorary State Secretary before the CME program. In that year, sir, please check, Rekha ma'am, please check that the Honorary Secretary is there. In that year, sir, you were dynamic secretary. So rounding throughout from Kanyakumari to Delhi, is roaming around all the places. If sir is there, sir will give the Honorary State Secretary address. Otherwise, sir will join at any time. We'll move on to the CME program. May I request chairpersons and moderator of this today's program. I request Dr. N. Subramanian sir and Dr. K. Venkatachalam sir to start the proceedings, introducing the topic and the speakers to this audience. So with this, may I request Dr. Subramanian sir, please take over and moderate the session. Over to Dr. Subramanian sir.
Good morning, Chairman Dr. Jayaraman sir, and all the members of Academic Committee, and all the office bearers from State President, President-elect, Past President, and Secretary, and other members of the Academic Committee. So it's a pleasure to be the moderator for this first program of this 2023 year. The topic has been as clinical problems in extremes of age, which is right at the right time when the winter is fading and also summer is coming up. The children and the elderly population are the most vulnerable, and we are going to have a great talk by Dr. Magesh on geriatrics and Dr. Narmada from pediatrics. The first is about clinical problems in extremes of age at geriatric perspective. Dr. Magesh, he was trained in UK in Newcastle University and worked in Hartlepool Hospital as a consultant geriatrician before moving back to India. He is currently working in Apollo Hospital, Chennai as geriatrician for the last 15 years. He is probably the youngest physician working for the elderly care. Now, the elderly, we all will get to that age at some point, whether you classify as 55, 60, or 70. So a lot of problems in terms of mobility, joint disease, eyesight, memory issues, and also neurological problems, leave alone the cardiovascular and other problems. So he has got special interest in falls, COPD, and Parkinson. He is a very good speaker and also active academician with lots of publications in international journals, and has been a speaker in various conferences. And it's a pleasure to welcome you, Dr. Magesh. Over to you for sharing with us about your perspective on geriatric care in India. Thank you.
Thank you, sir. Thank you for the kind.
Before that, we have President-elect Dr. Abul Hassan sir. Welcome, Abul Hassan sir, President-elect of 2023 IMA TNSP branch. So we are proud to have this in this academic committee forum, sir. With your blessings, we will be starting, sir. Kind request to you to give some felicitation address, sir. Abul Hassan sir.
Good morning, all of you. Dr. Jayaraman Subramaniam, TNSP President-elect Secretary, and my dear friends and the speakers, Dr. Magesh and Dr. Narmada. I wish the academic committee's first meeting in this year grand success. And I am very happy that, in spite of all the troubles we face in our profession, we continue to have this kind of continuous medical education. We all know that IMA was started mainly because of this objective. Later on, we expanded to service, social service, and also union activities. Anyhow, medicine is a very expanding one. Every day, new things are coming up. We have to update all the knowledge that are coming up in medical profession every day. For example, I can quote, yesterday I read there is a treatment that has happened in the chromosomal disorders that have been kind of troubling the patient without any kind of cure. Now they have found the cure that no more the chromosomal disorders will inherit to the children. They have kind of modified the faulty chromosomes in the mother's cells, and so these chromosomal disorders will not inherit anymore to the children. This is a very great development, milestone development in a modern medicine. So like that, so many things are happening in our this kind of CME activities definitely will update the knowledge of our members. And I wish academic committee of IMA TNSP under the leadership of Jairam and Subramaniam will continue to hold the flag of IMA flying in academic aspects. Thank you very much for the opportunity. I wish all of them have a great day.
Thank you very much, sir. Thank you, Abul sir. Over to CME, Dr. Magesh sir, you can start your presentations.
And members are requested to type in their questions in the chat box and also note down the questions. We are just reaching up to 92 all total numbers. So best wishes.
Thank you, sir. I wish to thank the IMA Tamil Nadu State Branch Academic Committee for choosing geriatrics as a topic in this August forum. And I like to thank Dr. Jayaraman and others who have given me this opportunity to share my views on the geriatric perspective. And start to share my screen.
Slide is not visible, sir. Hope everybody is. Yes. Thank you.
So, in the introduction, it's a very difficult to cover the clinical problems in geriatrics, and a lot of the problems were highlighted by my introducing doctor, that there are several problems in the elderly, and one of the key things I thought to focus on is, what is geriatric, what is elderly? Like, people are asking, a lot of doctors, colleagues, 50, 60, 70, 80, what age do you say it is? And during the course of my talk, I hope I would try and demystify how to approach an elderly patient. So clinical scenario, we'll all like to relate to clinical scenarios. This was a true patient, 87-year-old Mrs. Kamala. She came in with abdominal pain and she was unwell for 2 days. She was seen in the emergency room where she was tachycardic. Blood pressure was normal, but she was breathing heavily, and the saturations were normal, but the lactate was high. And she was started on IV antibiotics. Usually it's common for elderly women to have urinary infection, which becomes urosepsis, and she was transferred to the intensive care unit. After the middle of the talk, I'll come back to explain to you what happened to her. And this is another patient, Mr. V, again 89-year-old, who had poor mobility and gradual onset of confusion over 3 weeks. A few weeks prior, he was seen by a neurologist who advised Syndopa because he had some features of Parkinsonism. But this time, he was admitted in emergency in a confused state and with urinary incontinence. There was no fever. He was started on IV antibiotics, again presumed for urinary infection and urosepsis. The neurologist had seen the scan and lumbar puncture to exclude meningitis because of the confusion. So just look at why we are seeing so many elderly patients now. I mean, 25, 30 years ago, it was uncommon to see 80-year-olds in hospitals, whereas now it is very common. If we see the blue line, which is the Indian demographic, post-independent, the life expectancy at birth was only 20 years. And even up to mid-1995, it hadn't crossed 55 years. But now we see currently the life expectancy at birth is about 70 years, 69 years. So in India, this has changed, and this is due to various factors which we will not discuss today, but mainly due to improvements in cardiac care and infection control, apart from many epidemiological measures, which is beyond the limit of this talk. So if we see at birth, it is for India currently 70 years approximately. But if you look at life expectancy of those who have reached 60 years, then it is 18 years further, which pushes it up to 78 years. And if you look at 80-year-olds alone, those who have reached 80 years, they will still have another average life expectancy of 7 years. So if you see an 80-year-old, then you can think of them having an average of 7 years more. And we are reaching Western standards in terms of life expectancy. So I'd like to discuss about this pensioner study in UK. The study is very valuable because it looked at 25 lakh pensioners from late 1980s, and they looked at their health data. And these are people who had worked all their life up to the age of 60, 62, and they were paying a pension, and they had to give their statistical data about their health conditions, their blood pressure, medications, and this was collected over 20 years. And what they found was inequality in mortality. So the death was unequal among this group of people, and they were trying to look at what were the factors which made the life expectancy unequal. So they compared that people who died early in this 25 lakh people versus those who died late, those mortality was longer, those longevity, life expectancy was longer. The significant factors were those who had a low income at their retirement, those who had some sort of ill health at the time of retirement at the age of 60 or 65, and those who continued to have an unhealthy lifestyle. So we broadly know what unhealthy lifestyle is: smoking, drinking, overweight, less physical activity, and these are the factors. Those who had these three factors, their life expectancy at 65 was 12 years, which is the average life was 75 to 77 years. But the other group, which seemed to have who had an higher income, who had normal health at retirement and had a healthy lifestyle, there was a significant 10-year difference between these two groups. So they went on to live up to late 80s. So this is very important clue, which is what our intuition would be, is that those who have a healthy lifestyle would live longer. But another non-medical significant factor is the income. So people who seem to have an higher income, maybe because they can have more resources in their old age, access to more resources, generally seem to live longer. So we can clearly see one of the factors is the differential longevity. So any 60-year-old or 70-year-old who we see in clinical practice, it is difficult to treat the same. 65-year-old who's having a higher income and not having many problems in terms of diabetes, hypertension, and who continues to walk and live a healthy lifestyle, its life expectancy is going to be way higher. And we have to think of them as healthy 40-year-olds, how we approach healthy 40, 50-year-olds. And this is a broad rule, but then there will be, as we take history, there might be various other factors. But if you want to look at it in a simplistic way, so any 60, 70-year-old who has a healthy lifestyle and who has normal health and who has no good income, there is no financial strain, we have to approach medical problems as a healthy 50-year-old. And further, they looked into these two groups, whether just living longer doesn't matter, whether they are living healthily. Is the life expectancy, the increase in life expectancy gives them good, healthy years. And there was definitely a significant difference. The number of years spent in ill health or bad health for the people who had a lower life expectancy was higher, 10 years, about 9.7 years, not in good health. And then those who are a healthy lifestyle and higher income, their ill health was only 7 years. So if you look at it, they spend only after their 80s in ill health, whereas those who had a unhealthy lifestyle and poorer income, they spend most of their 70s in ill health. And this, they went on to look at what was the contribution of each factor, the number of years for their longevity. So first point I would want to make today is life expectancy is variable. So note, if you see two 70-year-olds, they both will not have the same life expectancy. It depends on many variables. And why are elders different to normal adults? Because of their vulnerability to stress. And this is because of the age-related reduction in their physiological reserve. And for us as medical community, we have a difficulty in measuring this reduction in physiological reserve. We can kind of see a rise in creatinine sometimes and say the kidney function is reducing. We can look at heart and kind of, if there is a clear reduction in a kind of ejection fraction, we say the heart function is reducing. But this is pathological reduction. But when there is physiological reduction, that is not, there is no good test to measure a reduction in physiological reserve. So this makes the assessment of an elderly person more of a challenge. And also there are a lot of chronic diseases which we all are aware of, which makes them vulnerable to stress. So if we kind of look at this illustration, the elder man who has reduced physiological reserve is still functioning well. But when there is a sudden hospitalization or a severe pneumonia or some acute illness, they suddenly collapse. So we can see people coming with great amount of confusion elderly, and people think it's dementia, but in effect, what they're having is a delirium or a confusion because their brain reserve is reduced, and an infection in the lungs or in the urine presents as a brain problem like confusion. So this is what leads to another difficulty when we are facing an elderly patient. So this term of reduction in physiological reserve, they've coined the term homeostenosis, where the elder patient is not able to respond to a stressor like an acute illness or a fall, where all the systems or one or two more systems collapse. But at baseline, they are able to live in a state where they're able to function well. So the son or daughter will say, even yesterday, last week, my father was walking to the shops, was doing well, but why, doctor, why is he confused today? And sometimes it also leads to accusations. Only after the admission, my father has worsened. He was fine yesterday. All this is because of not able to understand that the elderly person is already having a diminished functional reserve, and this one infection or a fall is enough to tip the point. So whereas one organ system, like when they have an urine infection fail, the presenting complaint may be in a different organ system. Another concept which we are very familiar in geriatrics is frailty. Frailty, it is defined as kind of increased vulnerability resulting from both age-associated decline in physiological reserve across multiple physiological systems. And this reduction is kind of compromises their ability to respond to a stressor. It is a very complex thing to measure. There are various tools people are trying to, still in research process, trying to measure frailty. So when in geriatricians or intensivists face an elderly person, instead of rather looking at their number as 80-year-old or 70-year-old, they are looking at this as, is the individual elderly person frail or not frail? And how to measure frailty? There is no instrument or no test to measure frailty. So right now, what we are looking at is various scales to measure frailty. There are various scales, but the commonly used is the clinical frailty scale, which has many studies and it's well validated. Simple way of asking or looking at in your practice, when most of the practitioners have only few minutes to talk to their patients in their busy practice, is to ask, whether you go outdoors independently. So if a 80-year-old is able to walk out of the house to the shop independently without any supervision or aid, then they are deemed as not frail. So they'll fall into the category of frailty score 1 to 4, but deemed they are not frail. Then if they are never leaving the house, they are not able to leave the house because of physical disabled, either they're breathless, their knee pain, and their joint pain, and they are not able to look after themselves, then they fall in the frailty category. And then once they are really bedbound, then they are classed as very severely frail, score of 8 or 9. So this is the way generally the approach to an elderly person is, rather than simply putting an age as a number, is to look at age and frailty. And there are other many scales like activities of daily living, which also give us a clue of how frail or how weak the elderly person is. So generally, it is kind of accepted in many ICU studies which were done in Europe and America with several thousand patients. When the elderly person in ICU, if their admitting frailty score was more than 6 or 7, their chance of death was very high. And measuring frailty was helpful in clinical decision making. So coming back to this first case, 87-year-old lady who came with abdominal pain, was started on IV antibiotics just to see what we did with her, because she, going through the history with the family, she had vague pains few days ago coming to emergency, and she was seen by a home visit doctor who gave her some antibiotics presumed for urine infection. And because she was not getting better, they brought her to the emergency. And asking about more about her lifestyle and what she was mostly at home within the bed and only able to move 1 or 2 steps. So, and the ultrasound abdomen we did showed necrotizing pancreatitis. So here we have a lady with a frailty score of 7 or 8, and she was elderly, 87. So if you look at her life expectancy from the age point of view, is few years maximum if she didn't have an acute illness. And here she has a very acute, severe acute illness. Necrotizing pancreatitis, as we all know, has a very high mortality even in a younger fit person. So because of, and there was a need for ventilation because she was starting to require more oxygen, and their respiratory compromise was happening. So these all factors suggested a prognosis is very poor. So this was explained to the family, and we counseled them not to go for ventilation and go for palliative care. And her wishes were to move to her ancestral home in Srirangam. And from Chennai, in an ambulance, she was moved there, where she was in her home for 24 hours, and then she passed away peacefully. This was what we class as a good death in geriatrics, is not to put an elderly person through all the machinations just because we have access to it, but look at other factors which will influence outcome. The other case we presented, the 89-year-old Mr. V, who had poor mobility and had seen a neurologist and started in Sindopa. He was having a good quality of life. He was moving around for social functions. He was a retired IFS officer. He was contributing to the society even in his retired age, trying to mentor various non-governmental organizations. And even a week before the admission, he was at a social function giving a talk. So his frailty score was not at all high. He was not classed as frail, and he was not so unwell needing mechanical ventilation. His oxygenation was good. And further workup, we found out his calcium was very high, and the PTH kind of clearly suggested the parathyroid adenoma is the cause for hypercalcemia, which is a correctable condition, which was corrected with IV bisphosphonates. So he didn't have a severe illness. He didn't need mechanical ventilation, and he was not frail. So only factor against him was his age, which was 87. But so we went for aggressive intensive care, and we also counseled the family that in case if he kind of collapsed and needed ventilation, we'll give him ventilation for a short duration and trial of ventilation if needed. So the approach was different in this person, even though both our patients were similar age group. And he went on, discharged from hospital, mobile. He was living for another 3 to 4 years independently in his house. And he was a little bit weaker than what he was before, but still very alert and contributing. And he even wrote a book on his life experiences after this discharge. So it is we have to be very careful when we assess an elderly person. We can't just choose our approach or ignore them just because they're very old. So this clearly illustrates decline in function and loss of independence doesn't happen in every aged person. It's not just the number goes up, everybody's function reduces. Because we have time, I'll quickly go through 2 other scenarios. This is an outpatient setting, an 82-year-old with diabetes for 5 years, whose fasting sugar was 135 and postprandial 195, HbA1c 7.8. The son was concerned the sugar values were high, and he himself being a diabetic, the son's HbA1c was 6.57. So he was kind of trying to tell his father to avoid, follow a stricter diet, and he wanted us to see if we needed to, optimize his medications. The other scenario was an 85-year-old lady with hypertension, a routine check, the cholesterol was high, 230. Would we start statins? So this concept of like time to benefit I wanted to introduce is the time we start an intervention to the time the benefit is observed. So these two scenarios is like a preventive medicine. The sugar control, the glycemic control is for preventing retinopathy, nephropathy, and all the secondary complications of diabetes. And the reason to treat dyslipidemia with statins is to prevent myocardial infarctions and strokes and atherosclerosis. So we have to understand this lag time to benefit is how long do we have to treat people, or how long to have a strict glycemic control to observe benefit. This is from one of the statin studies in patients with heart failure who were taking statins. Those who the time to benefit was at least 1.5 to 2 years. See, if you see up to 2 years, both the lines, those who were on statins and those who were not given statins, the curves, the survival curves is close to each other. It's only after 2 years the survival benefit separates out. So if you're seeing an elderly person whose life expectancy is not more than 3-4 years, then the indications for statin or the benefit of statin in prevention, primary prevention, is not that great. When we talk primary prevention, it's when they have not had a cardiac event or a cerebrovascular event. Once they've had a cardiac event or cerebrovascular event, the benefit is much higher. So we shouldn't kind of use the evidence interchangeably. So this was looking at the population studies in Western data. We don't have Indian data. So generally, what is the lag time to benefit for various interventions? So for intensive blood pressure control, so if we start antihypertensives to control blood pressure less than 130/80, the time to benefit is 1 year. And same for statins, we discussed now, the lag time to benefit is 2 years. And for intensive glycemic control, it's 8 years. So clearly, if the life expectancy is definitely not 10 years or more, the benefits of intensive glycemic control don't start appearing. So if you look, just to recap on the life expectancy, so at 80, the life expectancy is 7 years. So if you go back to our scenarios, the 80-year-olds with fasting sugar of 135, HbA1c 7.8, the son was counseled that no, the intensive glycemic control is not the priority in this gentleman. Rather, we have to avoid hypoglycemia, which we see very common because many practitioners and also families and patients are worried about their sugar because of what they read in the press and advice. They all want to have very strict glycemic control and end up having hypoglycemia and attending the emergency room. That is much more catastrophic because with each hypoglycemia, there is intensive neuronal loss. Their brain function reduces. So in this age group, in the elderly, our main focus during a diabetic review consultation should be on how to avoid hypos and inquire them about have they had any hypo episodes already, and try to encourage them to eat meals on time. What we commonly see is their breakfast time is very prolonged. They take it after 9 or 10, especially the women, after taking care of everybody in the family. So to try to keep the gaps between meal times as little as possible, and try to avoid longer acting sulfonylureas in the elderly. So sometimes what we do is revise the prescription once they become elderly and frail, is to avoid longer acting sulfonylureas. The other lady with, who was having high cholesterol, clearly, it is statins for primary prevention is not indicated. She's not had a cardiovascular event, so we didn't choose to use statins. So what do we tell healthy elderly when we see in clinic is one thing is falls are very common as their reserve reduces. So physical activity and no strengthening of their quadriceps and core muscles definitely reduces the risk of a fall. Is to encourage them to have mild non-weight bearing exercises initially and go for regular walks as many of us do already. And this is an article published about the prevalence of osteoporosis from our center a few years ago. Again, declining bone health is a cause of poor mobility and fractures, fragility fractures. Often fall and a fracture is associated with the decline in function of an individual. So strengthening bones and muscles are very important in the elderly. And we found out that osteoporosis in asymptomatic, this is people having routine checkups, having a DEXA scan, 27%, which is very high prevalence of osteoporosis. So just to be wary about calcium supplementation and encourage them to have regular exercises and regular walks. So hope I'm convinced that aging is not a disease. Thank you for the opportunity.
Thank you, Dr. Magesh. So it's a crisp talk about problems in the elderly care. I agree, yes, as we are going to live longer with technology and advancements and newer drugs, so we need to look after other factors too. And you rightly pointed out that the lag time to benefit, which I've been saying to many patients, that there is not much benefit in elderly with multiple medicines. Another thing I want to stress or maybe ask your opinion about polypharmacy, because now specialist care has been the norm. So every organ, people have different consultants, and the family physician role has come down. Although if they have affinity, they go to meet the family physician, but there are so many drugs with their prescriptions. So I would like you to explore on that. And another point you pointed out is the resuscitation. So that is important. Even last night I had a patient who was quite unwell, recent fractures, and looks like ARDS, but that the team is pushing for critical care. So, and she's 82. So the issues around resuscitation and the quality of life needs to be more explored among our medical colleagues. So that if you can explore that, then we'll take questions from the audience.
Yes, thank you, sir. Thank you for highlighting two huge areas in geriatrics, polypharmacy and end-of-life resuscitation. So polypharmacy, I think I'll try to keep it very short. It is a huge area, but in primary care in India, we are facing this issue of patients' affinity for the specialists and not letting go of their medicines, even when there is a clear role, there is no role for some of the medicines. And I think there is no easy answer to that unless the specialist himself kind of says, if you write a note to them and say clearly there is a risk of bleeding with dual antiplatelets, commonly used even many years after the primary angioplasty. So these kind of things, there is no easy answers. But at least the first problem is to scratch the problem is what Western countries have shown is the pharmacist's role, or somebody in the clinic acting as a pharmacist who can write down the medicines from various specialists and pointing out there are duality. The cardiologist and the kind of neurologist might have written antiplatelets, and the patients will be taking two different antiplatelets from two different specialists. So at least the gross ones which can be picked up and explained to them, I know they can be easily crossed off. For us as physicians, we have only so much time. It's difficult to get them to full medical history. So we need, like nurses, we need pharmacists or nurses who will be trained to write down the drug history, and encourage them. What I do is to ask the secretary or the staff to encourage them to bring all the tablets in a box, and one of the staff to write everything down, and then point out to them, these are the tablets which we wouldn't want you to have. When you ask your son or when you go to the consultant visit next, ask them if it can be crossed off. But then beyond that, it's difficult. I think polypharmacy definitely is a huge problem, and this iatrogenic problems, the cause of many problems we see for elderly coming into hospitals, most commonly is hyponatremia with the antihypertensives, which end in H. Tazloc H, Telma, whatever. No, sorry to mention brand names. Telmisartan hydrochlorothiazide, anything which hydrochlorothiazide is good in young people, but once they are 70, 80 with multi-morbidity and polypharmacy, they easily slip into hyponatremia. For elderly, they come with a sodium of 109, 110. We stop the drug, 3 days, they're back to normal. So I think drugs are causing a lot of admissions, like I said, hyponatremia, hypoglycemia is another thing where the specialists continue to have the same principle of tight glycemic control in elderly, which has to be avoided. So the second question I'll take is the resuscitation issue. In India, right now, we are moving in the direction, right direction with advanced directives in terms of courts telling now and trying to make the process simpler of when the treating team feels that resuscitation and intubation is not going to be of value, they can recommend to a board appointed by the hospital, and then the hospital's other board also agrees. Then within 24 hours or 48 hours, these process can be shortened. Right now, the process is very laborious, where the family has to go to a notary, and it takes weeks, if not longer. So it is not kind of a practical thing to get do not resuscitation with everyone's agreement. But I think the lot being talked about in geriatric forums and legal circles. So I believe in the next few years we will get guidelines, and kind of it will be used more often, and unnecessary resuscitation and ICU care will be avoided.
Thank you, Dr. Magesh. I'm just sharing few questions from the chat box. What is the age limit for geriatric, which you have answered? And what is the safe food and the lifestyle modifications would you advise for people with elderly?
Yes, I think keep moving. I think our body is designed to move. Encourage them to move. If they are only housebound, ask them to move within the house. Any elderly, if there is no stopping factors, ask them to be mobile, and of course safe mobility. If they have to go out, then make sure they have somebody to supervise them, because the roads are getting dangerous. So there is a balance in how we advise them. So try to understand where they live and try to ask them to keep mobile. Most safe thing seems to be if they're living in community dwellings like apartments or individual houses, to walk at least within their compound every day, 2-3 times a day. Adequate hydration, which is often missed with the summer months coming. Encourage them to drink plenty during the day. From usually I say, measure and drink, hydration 1 liter at least before 12 noon. So hydration and diet, the South Indian diet is very short in protein. So is to try and encourage them to buy more pulses and nuts and include that in their diet. So these are very common generic advice. Of course, for some patients who have ailments, this may not suit. So that has to be modified.
Thank you, sir. Thank you. Another question posted, is DNA legal in India?
See, I think the best principle of any decision applies. So what we do, if it is deemed best practice by the people judging you, if it becomes a legal issue, is where we stand. So it is very difficult. So I don't think it is fully legal, but they are establishing a process for making it legal, which is if you're working in a hospital, the hospital has to appoint a board, like an ethics committee. They have to appoint a board for this. So the treating team, if it's an intensivist and the primary doctor, they both kind of say this patient is not for resuscitation. The hospital board, they have to review it and they have to accept that independent. So they're not involved in the care of the patient. So they review and say, yes, this decision not to resuscitate is appropriate, and the family is agreeing to it. So the tricky bit is the family members, all of them, if they're agreeing, it is easier. If some of them, it happens sometimes, they don't see eye to eye, they act out of their guilt, they want everything done, then it becomes very difficult. In Western countries, it's very clear. The decision is the patient's decision. If they're not confused, and then the treating teams. But whereas in India, the factors of family and family members' decision also counts. So I think it is evolving. So as doctors, if you are faced with the situation, it is the legal system is not fully behind you. You're rightly, the person who asked the question is very right, that we have to be very careful. If you're not trained to do this, you don't have your hospitals backing in this, don't do this.
Thank you, sir. So as a rheumatologist, we tend to see more patients after the fall, but then when you get to the bottom of it, it's either visual problems, hearing issues, or a joint disease with arthritis, or even early Parkinson's. All can be viewed as problems resulting in a fall and osteoporosis and fractures. So those, for the members, those also need to be looked at when you assess and analyze the patient with any geriatric age group. Any more questions from the chairman, sir, or other members from the academic team?
Very nice, Dr. Magesh sir related all about the common illness in geriatric population. Sir, I want to know your take messages from our our audience point of view. So about the vaccinations, about the prevention of osteoporosis and prevention of dementia or Alzheimer's disease, any mental brain work to be done periodically to engage our mind brain in the active way to prevent or postpone the dementia or Alzheimer's. So just I want to highlight you about the take messages. Yes, sir. Magesh, sir.
Like
very briefly, yes. I think, see, keep moving. I think when you move, your vascular system is charged. So for vascular dementia, if you're moving along with your other prevention, you reduce the chance of vascular dementia. And learning a new skill. So 60, 65, if you have a hobby, start learning. If people couldn't learn music when they were young and now they have the time, learn something new. So learn a new activity, be engaged socially, don't withdraw. I think social isolation accelerates dementia and depression. So I think be engaged socially, and no, children have to contribute or pitch in. If the parents want to go for a wedding, they have to make arrangements. So encouraging the children that know that social engagement is very important. So be active socially, keep mobile, have a good nutrition. Don't, I mean, the appetite and the food capacity reduces. But no, to kind of eat quality food, have a variety in the diet. So these are the messages to prevent, to postpone cognitive decline. And in terms of vaccination, yes, annual flu vaccination and one shot of pneumococcal vaccination is advocated, especially in winter months. Now we're getting more attacks of flu. So these are kind of broadly followed for everyone. Thank you.
Thank you, sir. Thank you.
Thank you, sir. Any questions from the audience? You can unmute and ask, or you can type the chat box.
A patient with repeated fasting high, PP and HbA1c is under control. Only the fasting is high. Is on Janumet and Voglibos. 5500 Janumet, sir.
Yeah.
And the Voglibos OD.
Yes, I think when what is the aim in this patient is what I would think. If the aim is HbA1c is reasonable and is otherwise active and his life expectancy is not more than 10 years, I wouldn't worry too much. Just try to counsel him and find out why the fasting high and see if there is any.
Repeatedly in 150, around 150 to 155. But PP and HbA1c are under control.
Yeah, I wouldn't worry too much, madam. I think preventing hypos is what is the main take-home message for the very elderly. So it doesn't cause any harm because it takes about 10 years for poor glycemic control to cause any end organ damage. So I wouldn't worry too much. Just ask him to do more physical activity.
Anything alarming, sir.
Just ask him to improve his physical activity and keep checking his fasting. It may come from.
He's very active, 70 plus.
Ask him to increase his physical activity. Increase his physical activity in the evenings and see whether the sugar responds. I wouldn't touch his medicines. His medicines, perfect.
Exactly.
Okay, sir. Thank you. Thank you, sir.
Hello, sir. Hello, sir. Hello.
Yes. Okay, ma'am.
Yeah. Thank you for that wonderful lecture, sir. So can you just give your advice regarding recommendations for calcium and vitamins? Milligrams.
Oh, yes. I think daily calcium requirement is 1 gram of calcium. Vitamin D is 400 units. We do have various dietary like milk and egg, which contribute a little. So I think if the patient generally doesn't have a contraindication, they can take 500 milligrams if there is no suggestion of osteoporosis for tablets. But no, I think if you are measuring osteoporosis in the DEXA, then it depends on their score.
Yes, sir. Multivitamins, do you advise zinc, trace elements? Do you, all these branded items that keep coming off the shelf, would you advise, sir?
Not routinely, but if they're on metformin, no, we think of B12 deficiency and B complex, so you do supplement the vitamin Bs. And I would just leave to your clinical practice and judgment what works best to do it. No huge impact, just broadly giving minimal vitamins. I think the target to your patients what vitamins you want to give, it will be helpful.
Okay, so thank you so much.
There is an interest among the patients to want some vitamin in their prescription, whatever the age group.
Yes,
that's the Indian patient's mind.
Yeah, what I tend to do for that patient is to ask them to take it at a time when they're not taking other medicines. I tell them the more medicines you take, the ones which are supposed to work well won't be absorbed well. So that puts a doubt in their mind. So, and then I ask them to take it maybe lunchtime or coffee time. So,
thank you. So if there is no more questions, I once again thank Dr. Magesh for his excellent interactive lecture on clinical problems for Jerry. And we will hope to see you back again sometime later in the year. Have a nice day. Thank you.
Thank you, sir. Thank you. Before going to the next talk, small announcement about the TNMC credit points. Those who want the credit points, kindly type your name, email ID, registration number, as well as your mobile phone. And we have put up in that chat box, there is a detail online transactions. That is Indian Medical Association AMS. Account number 75260-10000-1890, Bank of Baroda, Teni branch, IFSC code BARB 0 TNX. So kindly note down for the credit points certificate and all. Thank you. Over to the next speaker. Subramani sir, you can introduce the topic, next topic.
Yes,
and
yes, sir. Yes, sir. Sir, Jairam sir, the payment, there should be a timeline, like next 48 hours, something like that, so that the
maximum
can be
maximum
applied.
3 days. Yeah, within 3 days you have to make the payment, online payment in the Indian Medical Association AMS account. I have given in that chat box. Kindly go through. ₹100 for the TNMC credit point certificate. So kindly go to that. Any queries, you please feel to ask our members or me. Thank you.
Thank you, sir. So next over to Dr. Namada, next topic. So she's going to give us a brief overview on clinical problems in pediatric age group. Dr. Namada is a well-known pediatrician and past Women's Wing State Secretary. She's the alumni of Coimbatore Medical College, then did DNB Pediatrics in ICH Chennai, and subsequently had done MBA, Diploma in Allergy, Asthma Care, and also a fellowship in Royal College of Child Health. She has been working in the Nalla Medical Center as a consultant pediatrician. And last year, she was a national vice president with the Pink Health Mission, and a very vibrant, active person around the IMA. She's got more managerial response as well as academic interest. She is also my wife's schoolmate. So welcome, Dr. Ramada, ma'am. Please give us an overview of pediatric age group clinical problems, what we are encountering, especially after the COVID era and also for the future. Over to you. Welcome. Thank you.
Thank you so much for the kind words, sir. And it's a pleasure to be on the platform. I thank Dr. Jayaraman, sir, for giving me this opportunity to speak before you all. And can you see my slides, sir?
Yes.
So
put it in the slideshow. That will
yes,
be fine.
yes. It was a very interesting presentation by this previous speaker. Now we are actually switching gears and changing to a pediatric experience. So coming to that, one thing is it's got a lot of pictures and video and is being used only for the presentation because consent has been sought from the parents only for this. And I request anybody is recording it not to share the pictures or videos, just a small request from my side. The introduction, Dr. Mahesh beautifully described about the concerns of a geriatric age group. So we will see what is the uniqueness of the pediatric age group and how do we recognize the sick child in the clinic and the common clinical problems we are coming across in this age group and the conclusion. Now, as we know, the pediatric age group is a very multifaceted specialty because we tend to become, we are following them from the gestational period if they're having any problem. And that goes on to the infancy, childhood, adolescence. And not only that, even after the child has got into the adult age group also, still they rely on us for multiple opinions and we become almost like a family physician to them. As well as we have to deal with a developmental disorder because a congenital anomaly can present as an infection, the metabolic disorders can present as a sepsis, and the age group is also very much evolving. It's not yet completely set. So sometimes they would have seen the child at 3 months of age when that is apparently the child appears completely normal. And then they come back at 7 or 8 months when there is complete lack of head control. At that time, we asked them, why didn't you come before and you could have told me? They said, நான் உங்ககிட்ட தானே டாக்டர் ஃபாலோ பண்ணிட்டே இருக்கோம் அப்படியும் வந்து தலை நிக்கலன்னு இப்ப வந்து சொல்றீங்கன்னு. So it is a very dynamic specialty. So we'll have to be very careful, tell them that they have to come back here. And the challenges of nutrition is very largely looming because whatever we say, even in this, there was a thing on nutrition of the older age group. So more so in pediatric, what to give, what not to give, starting from the infancy and to adolescence. So it's a very unique specialty and unique clinical problems we face as a pediatrician. So, but what I found it very clinically relevant is what I learned in my PG days. We were a single PG sitting in a very busy OPD in ICH. Among hundreds of children who are coming, we need to pick up the most sick one. If they collapse in the OPD, then the senior most PG will be held responsible. So what helped us was to look at this triaging, which is just 6 seconds. We have to assess the child by the appearance, the work of breathing, and the skin. So as soon as the child enters into the clinic, if you look at the appearance itself will tell you whether you're dealing with a sick child or not. This is a very, very important one because children always have convulsions while waiting for the OPD. They may come with a high-grade fever. They may develop severe respiratory distress while sitting in the OPD also because their circulation and their respiratory system is very dynamic. So what happens is if they develop a convulsions while sitting in your OPD, completely you will be at fault for making them wait for more than half an hour. They'll completely blame. They will forget what happened before in their home. They'll say that the child waited for a very long time and that's why the problem came up. So we need to not only know the triaging by ourselves, we also need to teach our staff about the triaging because by the time they give their names, they will have to know which is a sick child. So look at these two children. Same respiratory distress. And this is the second child, same respiratory distress. But when you look at the first child, is completely a lethargic child. This is bordering around respiratory failure, and this will require your immediate intervention. And probably, if you're not having a higher facilities there, you might need to refer to a higher center. Whereas this child, you can take your time and you can do the necessary intervention, then plan for further management thereon. So this way, the triaging becomes very important in the pediatric age group. We need to decide the sensorium, the appearance of the child is of a paramount importance. And then what do we rapidly assess is the airway. A child who is crying for me is it's better than a child who comes very silent. Similarly, a child who comes with respiratory distress with an altered sensorium is much more dangerous. So we have to make a rapid assessment of the airway, breathing, the circulatory status. So my professor, Dr. Tangavel sir used to say, always fall at the feet of your patient, meaning The circulation, whenever I'm examining, I'll just touch for the dorsalis pedis, look at the warmth of the ankle as well as CRT while I'm examining the patient. Well, if you do that itself, circulation is almost normal, then we can proceed on. Disability refers to the fever as well as the exposure actually will help you out more in a pediatric age group to point what is the source of the illness, and then only comes the investigation. Now, there is a vast spectrum which we have spoken about. So I'm going to stick on only the 4 types, which common problems that come across in our clinic. This is a season where we got a lot of respiratory illnesses. We had fever. Now the diarrheal illness will come up as April and May season comes, and not to forget the seizures, which quite often present in our clinic. So the common disorders we see in the respiratory age group is newborn up to 2 months. They come with a very normal breath sounds, usually is perceived as abnormal by the parents. And goragorana sattam varudhu. Now this is a very commonest complaint, and they will have a load of antibiotics and decongestant. We will have to reassure that there is not at all any issue and the child is normal. This has to be very closely differentiated from bronchopneumonia, which can present only with respiratory difficulty because fever is not seen in the newborn period at all. The other thing, in 2 months and up to a year, we get more of an URI and bronchiolitis and bronchopneumonia. And now we get a lot of recurrent episodes of wheeze, and child keeps coming back. In 2 to 5 years, it's more of asthma and again bronchopneumonia. And more than 5 years, it's asthma here. So this is a normal breath sounds perceived by the mother as an abnormal. This you can see that the child also had an increased respiration also, but the child is very active. A very sick child is not going to have this complaint. So we need to only, it's more of a conducted sounds. When we are going to see with the stethoscope, it's more of a conducted sound. So what it needs is only a reassurance, probably a nasal saline drops, and tell them if the child is very lethargic, not feeding well, to come back. So this will help. The activeness of the child is actually going to help us differentiate from an upper respiratory infection. In comparison, an abnormal child will be, abnormal newborn will have a difficulty in breathing, may have a low saturation, and will be very lethargic. The lethargy will point out to an abnormal child. Now, coming to the beyond 2 months, as I told you, this is a URI with a nasal block and secretion. They would have come on the first day with an upper respiratory infection. Very fastly, it will progress on to the bronchiolitis, requiring even a CPAP. So they may look completely normal, but always check their saturation. Sometimes we do give adrenaline nebulization, but humidified oxygen is the mainstay of treatment, and they may require non-invasive ventilation. The changeover from URI to bronchiolitis is very quick and very sudden. So always you have to tell the patients to come back if there is abnormal respiration or a lethargy in the same child. The bronchopneumonia can present only as a fever, and symptoms begins very early. They may come on the first day with fever. They can land up with respiratory distress on the second day. We have to suspect a staphylococcal infection. Now, not only chest X-ray is mandatory, ultrasound chest has become the latest confirmatory diagnostics. It helps us to differentiate abscess, consolidation, empyema, collection of fluids. So ultrasound chest has become mandatory. Bronchopneumonia also presents as a there is a presentation of LRI with wheeze also as a bronchopneumonia. Both will have an abnormal sounds. So you have to be very clear when we are dealing with this. It is very depressing for the parents and clinicians, and it keeps coming again and again. Reassurance and talk about the immunity will be helpful. So one of the other respiratory problem which is very difficult is this ALTB, acute laryngotracheal bronchitis. This child will also present with bronchopneumonia only, but what happens is the sound will be apparently heard even in your OPD. So this sort of children will require urgent attention. They will also present with respiratory distress, and they will be very irritable too. So common respiratory disorders in the 2 to 5 years is a childhood asthma, and this will not present like a respiratory distress in an adult. They will present only with a cough. This is a cough variant asthma. So this child, if it is coming recurrent, and sometimes it will start off with the cough and end up in fever. but they will tell only about the fever and the cough. You'll have to be very clear and asking about the recurrent infections. This will clearly help us to know that it is a case of a cough variant asthma, and your management will be different, may include allergy skin testing also, which will say the atopic nature of the same. So sometimes the patients may present with sudden onset of respiratory distress and fever. When you ask the history very clearly, they will say that it is a cough with difficulty, and kerosene poisoning can also present with respiratory distress also. And it's a very tense parent. What is requiring is a careful observation, monitoring, along with the humidified oxygen. So you may get in the older age group an acute exacerbation of a bronchial asthma. Child will not talk anything, just present with the respiratory distress alone. This has to be picked up in a busy practice, because this child, you cannot, you cannot look at her, you cannot ask her to remove her dress, and she'll be just sitting there very silently with the respiratory distress and not telling. Some are very poor perceivers, and they will come in their completely acute stage when these saturations are dipping down. So this is what we see in the pediatric age group with regard to LRI. We also get pharyngitis and acute sinusitis, but they can be easily picked up in the pediatric practice. Acute sinusitis can come only as a headache. This is one of the commonest conditions that we see now, especially in the viral flu season. So you have to differentiate whether it is the headache due to the flu or it is because of the sinusitis. The pattern of headache has to be inquired. The reason we have to differentiate is the sinusitis, the treatment is little prolonged, difficult to treat, and it is presenting even in the younger age group of 3 to 5 years also. So sinus, we cannot keep it only in the older age group. The other thing, whenever the patients present with this respiratory complaint, we have to ask about this particular symptom. Can anyone put in the chat box what is your diagnosis for the same? This is your snoring. This is an adenotonsillitis presenting with the snoring. This child will definitely have a sleep disturbance also. One of the reasons is they will not tell you that this child presents with the snoring. They will just say, during the cold symptoms. So you will have to ask whether it is a snoring episode that is coming there. And it is very difficult. We have to treat them because it might involve ENT consultation. They may land up in hearing issues also. Video when the child sleeps is very helpful in order to differentiate, because seizure children also present with frothing in the mouth. So this is what we see in the respiratory disorder. When you get a noisy breathing, it can be more of an upper airway obstruction. When you get a silent child with a respiratory distress, differentiate it from whether it's a respiratory distress or a failure, and see whether it could be a bronchopneumonia or a wheeze. Then it could be a disordered control of breathing, mostly due to poisoning or a neuromuscular disease. The next condition which we see in the pediatric age group is a fever. The confusion now it's occurring because it sometimes exceeds beyond 10 days also. It's always between the common harmless virus and less severe viral infection to a very systemic bacterial infection. We can't keep overact and over investigating, thinking of the serious bacterial infections, which is very less. And we cannot also underestimate thinking that it is a simple viral infection. So the criteria which we use is the Pittsburgh guidelines or the Rochester's criteria, where we look at certain investigations apart, because fever is going to present only as a fever, and the child may be or may not be very sick looking. If he is toxic, we'll definitely admit. If he is not toxic, what will help us is a CBC of it is outside the range of 5,000 to 15,000, and an absolute band count of less than 1,500. CBC will always a very, very helpful investigations, but not only the total counts you have to see, you'll also have to look at the absolute neutrophil counts, ANC, absolute eosinophil count, and absolute band counts. And urine, if there is a pus cells, it will again help us. When the stool is less than 5, these are low risk criteria. When the CBC is in the normal range, urine has no pus cells and stool has got less than 5 WBCs. Generally, we do the blood counts and urine, which will help us. Quite often, what is being done is a Vidal test, but let me tell you again here, we have stopped using the Vidal. Vidal is no more effective, and we know that only a paired serum sample can help. The baseline Vidal positivity in our children has increased from 1 in 80. Now it is present for all the children, and typhoid vaccination is also being given for all children. Even at 6 months, we have started giving vaccination for typhoid. So never use Vidal. Your complete blood count and urine routine will only help you. So the difference for us is this criteria is more for the Western environment, but here we have totally different standards. We may have dengue and tropical infections. So we have to use those criteria also. We have to take in the duration. If the child is very sick looking, we cannot wait till what the 5 days suggested. We might do even on the 2nd or 3rd day. And there is a uniform concept in the Western literature. For us, it is very different because children come from this, from the very downtrodden area to a very affluent society. So we have to tailor-made our investigation for the same. And we have only a very few time to assess whether the patient is really sick. So we have to look for the focus of infection apart from doing the investigation. So genuine pneumonia can present, as I told you, as only as a fever with no respiratory distress. But also look for the occult tonsillitis, very difficult to find out in a child who just doesn't want to open the mouth. You'll have to look at sinusitis. One of the commonest area where we miss the focus is in the otitis media too. We have to look at for hidden abscesses, rash, even osteomyelitis and arthritis. If they present with the febrile convulsions, we know it's a clear-cut CNS. But UTI again presents with no focus also at all. But hidden pyelonephritis can be there. Abdominal signs like hepatomegaly and splenomegaly, we have to pick it up because we should not miss dengue, typhoid, and malaria. Of course, malaria is less in my clinical practice. So, and one more other clinical signs which we see is the Eshkar. In the Tamil Nadu is becoming endemic, especially in Vellore. Most of the children present with the low platelets which are treated as a dengue, they usually have this Eshkar in their head, either in the axillary area or in the scrotal area. So fever of unknown origin, look out for the causes. Or they may come ahead with a subtle rash like this that can present. This is a viral induced rash, or even a streptococcal infection can present with a rash. So these sort of patients, so we need to be very careful. Fever with rash can mimic dengue, so we have to admit them, or if they are very toxic, or closely monitor them, ask them to come back. X-ray is a very important tool for finding out fever of unknown origin. We may have an occult viral pneumonias like this, or which this viral pneumonia itself can prolong for 10 days. In fact, all other investigations will be normal, only your X-rays will be abnormal, or they can present even as a consolidation. This child had fever of only a 2 days duration and came ahead with such a big consolidation here. So some must in fever is clinical examination is very much mandatory. Look for the hidden rashes, hidden Eshkar, investigate appropriately, and never stop from doing the blood culture. Doing a culture should be a culture for us, because typhoid cannot be picked up with Vidal, cannot be picked up with typhoid IgG, and you'll be stuck after 7 days when all the clinical signs point towards typhoid, and we are getting an extremely drug-resistant typhoid, which is not responding to the first line of antibiotics. So investigate also appropriately. And we see investigations asking for Vidal and platelets alone. It is not going to be of help, because complete blood count is going to give us a complete picture. We have other parameters that is going to help you out. And platelets alone might be falsely negative. It might be falsely low, because children blood clot very much immediately. So by the time they're taking the blood itself, the sample might clot. Even a micro clot can lead on to low platelets. So seeing the CBCs as a whole, along with the clinical picture, will give us a good diagnosis rather than doing Vidal and platelets alone. They may tell you that they don't have money, but if you have missed something, we are at the end where we're going to get problems. And we all know children, their deterioration is very, very quick compared to that of the adults, and they cannot voice out also. And one value of CRP is definitely not useful, because after the COVID seasons, we have all started doing CRPs. So, but one value is not an indicator and doesn't indicate that we have to refer the patient urgently. And one more thing I always felt as a pediatrician is never underestimate a mother's hunch. If a mother says that the baby is abnormal, but you feel that everything else is normal with the child, just you have to rely on the mother and go ahead and investigate further, find out if we are missing out something. Then the diarrheal illness. So this can present to us with the severe dehydration. Even now, children do present with sunken eyes and loss of skin turgor. The one thing we have to see is they present not late, they present even on the first day with severe dehydration. Then there is an endemic cholera that is going on. So do not blame the parents. We are missing something like an endemic cholera, maybe. So child just had 3 or 4 episodes and it have come with dehydration, very severe. And the loss of fluid, even 2 to 3 times in diarrheal illness in a child is much more damaging than a 2 to 3 episodes in an adult. So you might have seen the child in the morning, but by evening, the child may go skip in for dehydration. So always tell them about the danger sign and about the urine when they have passed the last pass the urine, and ask them to report back even if it is if the child seems completely normal but presenting with AGE and vomiting. So the other mimickers of acute dehydration which we should not miss is not only the diarrhea, but they also present as diarrhea and vomiting. So this child is an 8-month-old who presented to me at 1 year of age with severe dehydration and was treated more than 2 times with IV fluids and discharge. When careful investigations into the history, the parents said that after 2 episodes, the child who was like 8 months old had become like this. And when we noticed, we are looking out for all signs of dehydration and we looked out for the vitals. I have taught the triaging sisters to note everything. Only isolated tachycardia was noted without any signs of shock. Then when I asked into the history, this child has been like this. So then we knew that the dark pigmentation, repeated dehydration, led on to the condition for me to know that this was a case of a congenital adrenal hyperplasia, CAH. Her cortisol levels were too high, twice treated only as AGE with severe dehydration. Then once she was replaced with the hydrocortisone, this is the child you get which is smiling. And we should not miss signs of infant diabetic ketoacidosis that also present as fever. They will present as vomiting with severe dehydration. They have all signs of fever episodes and dehydration. We shouldn't miss the diabetic ketoacidosis there. The other terrifying part for a pediatrician is the seizures that come. And it is not can present as a complete a non-convulsive status. They need not have the full-blown tonic-clonic convulsions. They may just have a staring look or one finger or one part of the body being involved. We have to need a high index of suspicion. Also, they may present only as an irritable cry. So this child, if you see the staring look, the repeated tonic-clonic convulsions, mother had actually mistaken this for a cry and came only for an incessant cry. But what helped us was the staring look and the clonic convulsions we got, because they wouldn't present. For them, parents, they think that complete convulsions involving the whole body is convulsions. But this staring look will actually help us. So febrile convulsions usually present this way. So when they come with the febrile convulsions, again, age is an important criteria. Just like in geriatric, we will have to see the age, we will have to see the sensorium of the baby, and we will not investigate and go ahead with do LP for all the children. If it is a younger age group, a toxic, sick-looking child, even if they had an episode of seizure before febrile seizure, that episode we will investigate like that of a meningitis. But usually, generally, the criteria for febrile convulsions is children, the convulsions is less than 30 seconds, which means by the time they come into the clinic and enter into your chamber, the convulsions would have actually stopped. So this clearly tells us that this is a febrile convulsions. Whereas in a prolonged convulsions if the child is convulsing till the time they are entering into your clinic, it goes on, then we treat it only as a status epilepticus. So that child warrants investigations. So, and then it is only on the first day and it does not produce any cardiorespiratory compromise compared to the other children. But what happens is after the febrile convulsions, they may have a post-ictal drowsiness. They may have subtle convulsions like this, which needs your intervention immediately. Also, we have to see whether this is a special child. If it's a special child, convulsions, even a febrile convulsions can last a long. The sensorium again will help us out to find out what is the type of the child we are dealing with. And in the pediatric age group, whatever be the clinical condition, one question you can never answer is, my child never eats. What is the problem? So here we have to know the certain basic facts. Breastfeeding exposes the infants to a very wide range of food taste. So if they are not exposed to a breastfeeding, and the parents have been very picky, because we are a generation who are looking at young mothers who have also been picky eaters. So that they have also been given a lot of varieties of become picky eaters. And there is also a genetic so they wouldn't have eaten, the child does not eat. There is a genetic predisposition to bitter taste sensitivity, and these children will accept vegetables better compared to some children who do not like vegetables at all. Even with all these favorable factors, like they have been a breastfed child, the mother is properly feeding, mother has also eaten a lot of food, the child's acceptance of new food will be about 10 times. They will require 10 times exposure. And the parent-child relationship, the family dynamics, now only iPad and mobile is feeding the child. Gone are the days when the grandparents used to sit and talk to them. That was a very important part of our culture, which showed about the body language, which showed them about various eye movements, and the child learned even language while the child was being fed. So this is a very important factor here, and child's temperament also plays a major role. If he has been petted and pampered, the child will demand just to get the attention of the parents. So this, I will always tell them that don't worry, this is how your nutritional pyramid has to be there. But the child can be a choosy eater and a picky eater. But what we have to differentiate is if there is an avoidance restrictive food intake disorder, what will help us is have the growth chart, which is every time, find out if they are nutritionally okay. The choosy eaters might be small eaters, like they are eating only in like very small, only half a idli, 2 idlis, then again they'll come back after 1 hour. So I tell the mothers to keep the food accessible to them so that the patient, they just go and eat when they want. And they will be slow eaters also. So they cannot complete the meal in that half an hour in the lunch break. So here also we shouldn't encourage them to feed for more than 1.5 hours. They should complete the meal by half an hour. After half an hour, the plate has to be taken away, even if the child does not eat it. They may be junk food eaters eating a lot of sweets and chocolates and fried food. They will say it is only 1 biscuit. But I tell them 1 biscuit equals to about 40 to 80 calories, that almost about 1/3 of what the child eats, compared to us who needs about 1,500 calories. We need only 80 calories is nothing. But for a child who requires only 600 calories, this 80 calories is almost a big amount. So don't give the junk food. So we need to have a healthy food habits with a lot of patience and avoiding distraction, and never use food intake as a playtime. So these are something which we can tell the parents. Sometimes picky eaters also can be neophobic, any aversion to new foods, they don't want to eat it. But the question here is whether the nutrition is compromised. So there was a longitudinal study that showed that there was no nutritional compromise with these choosy eaters and picky eaters. They had just a low protein intake and lower intake of micronutrients, which they compensated when they became an adolescent. So they tend to be less obese. In fact, choosy eaters and picky eaters are less obese, but we have to just follow up on their growth chart for these children. So when we say them that they are fine, the other one question that we should always ask as a pediatrician is about development. As I said, they will never tell you what is the problem, but you can use the time you're interacting with your parents to look at this child. This was a child who came for vaccination. The developmental assessment for the motor, fine motor, takes only about 6 cents while we're interacting and playing with the child. So you can see the motor, gross motor when the child got sat by herself, fine motor when she was looking at the objects and turning around and trying to pick up new things, and the language communication which she's having the mother. So within 6 seconds, all your assessment of the gross motor, fine motor and language will be over. But we need to have this interaction with the patient. This question, the parents never tell you that the child is not standing or laughing or hopping. They will think that it is a normal. They will say that anyway, you should be very questioned. One question you should never ignore is there a multivitamin for forgetfulness? When they will be leaving your cabin, the question they will ask is, doctor, please write a health tonic as my child is not good at school. This is a huge Pandora box. I don't want to touch on that. The child may have dyslexia, specific learning disability, as well as maybe a slow learner. So when they are sitting in your clinic, you can ask them to fill this checklist, which is available freely on the internet, to find out whether they have any learning disabilities. So you will be the person who will help them out. And one more thing is, an adolescent is always a very different. It doesn't come under the pediatric. Neither they're sticking into the pediatric or an adult. So we have to be very careful because they will still keep coming to you. Use this HEDS questionnaire when you look into their education, activities, drugs, and safety. One question that embarrasses you is whether they keep coming to you often. We have to, this is a very complicated question because a normal child can come with frequent infection. They can have up to 4 to 8 respiratory infection. They can have up to 1 episode of pneumonia till 3 years of age. They will be normal growth and development. They will respond quickly to antibiotics and they will appear very healthy. Just rule out passive smoking in this age group and always watch out for signs of immunodeficiency, because that question embraces us. We will feel the child is normal, but there may be a hidden case of an immunodeficiency. So coming home, I just took a little more time, but the take-home messages are we need it triaging. Common things are very common. Pediatric, there are a lot of age-specific diseases, but we should also not miss on nutrition, development, and abnormal.
I was the honorary secretary for 2 years. Then I became president.
Rule out immunodeficiency if they're coming often, and it is a very much pleasure to treat these children because results are very gratifying. We need not wait for the time lag at all in pediatrics. We get the gratification immediately, and that's the fun of being a pediatrician. Thank you to all for the patient listening, and thank you to all the parents and the lovely angels who gave this video for me. Thank you.
And thank you, Dr. Namanda ma'am. So that is the eloquent and excellent talk about problems in pediatrics. You touched upon outpatient setting, intensive care, and also triaging concept. And you also explained about the like a Vidal test, which people are using nowadays. Positivity and treating typhoid and tonsillitis frequency. Very important that you have mentioned about the blood cultures importance and also the CRP. And how common do you see rheumatic fever with the raised TSR? So that is one question. Another one, we are getting more obese children nowadays, even young age. After the COVID, children have put on about 10 kilograms in 1 year. Yeah. Especially the early adolescents. So that's a big issue coming up. If you can explain that, and another point I have to highlight is the misuse of antibiotics. While little fever, viral infection, we are using more and more antibiotics for children, especially because of the concern about whether it's deterioration or not. So if you can explore that, please. Thank you.
Yes, sir. For your first question on a rheumatic fever, yes, even now I am getting cases, at least 1 or 2 cases per year. Last year, I had a 12-year-old girl who presented with respiratory distress, treated as an asthma outside. When I just put the stethoscope, there was a loud MR murmur and ESR was very high. So all these patients go as a respiratory distress. One child presented only with neurological manifestations. So rheumatic fever, yes, we are getting it, and we need to have a high index of suspicion for the same. On the same note, when I'm mentioning about rheumatic fever, I also need to say that AGN can also present. Acute glomerulonephritis is also a common presentation. They may present not even with puffiness of face or a pedal edema. They may not tell you about urinary symptoms. Isolated hypertension can be one of the commonest manifestations. So look out for that same thing, sir. And the other thing is about the antibiotics misuse. That is the reason I repeatedly told you in the respiratory problem about snoring, adenotonsillitis, the allergic manifestation, because all episodes and the normal newborn which I touched, because invariably for those extremes of age group only antibiotic will be given. They will say anyway we will give an antibiotic, why to be we will err on the wrong side, but it is not so. We have to examine clearly, ask a history whether it is recurrent. There will be always the allergic manifestations that is going on. So that is why antibiotics, and that is the reason I insisted on culture. Typhoid, we start on ceftriaxone. Second day, the child patients is not improving. We switch over to IV azithro, or we may go up even on piptas. And nowadays, I see people are started only with piptas and meropenem. So that is the reason culture. Start off on this and send the culture with the latest backtech methods. We get within 48 hours the culture positivity comes. That helps us a lot. So unexplained fever, always send the cultures for the same. So this next question you asked me was.
I think about the obesity.
Obesity, sir. That's a very big phenomenon that came up with the COVID. And that is why the nutritional advice always for a pediatric to know about the disease. URI, how much minute you will take? Only 1 minute for you to diagnose. The rest of the 5 minutes will be involved only in counseling. I always use the growth chart to tell them why the child has become obese, what are the side effects. And the PCOD, or I use that dark pigmentation of the neck, I tell them, that is what I said. One question they want to ask is, child is not eating, but you should ask about nutrition and development. They never tell you. They are not embarrassed. They think it is a norm. And if you see, it's a familial obesity because parents themselves are obese. So we have to tell them as well as about picky eating. So on the same note, when we had discussed about choosy eating and picky eating, again, we'll have to talk to them about obesity. Only growth chat can help us in that one, sir.
Thank you. Thank you. So just to go through our questions from the chat box. Precautions to be followed for a baby of a GDM mother.
Gestational diabetes mother, always look out for the any congenital anomaly. So second, an abnormal weight gain in the uterus, oligohydramnios or polyhydramnios should alert to you the concept of any problem in the neonatal age group. If they are developing respiratory, we have to look out for the respiratory distress and sepsis in the first 24 hours, as well as monitor their sugars more routinely for them, because they may have occult hypoglycemia and child will be found lethargic even before the next weeks. So monitor the sugar, look out for respiratory distress, as well as look out for their sepsis. By the 3rd or 4th day, if the child develops any respiratory distress, we will look out for any congenital anomaly in an infant of diabetic mother. So that has to be looked out, because even these are the main thing is sepsis, respiratory distress, as well as the hypoglycemia for the gestational GDM babies born to GDM mothers.
Dr. Narmada.
Yes, sir.
I am Dr. Sundaramurthy, pulmonologist, retired from Tamil Nadu Medical Service. So thanks for your nice lecture. You recall my teacher, Dr. Narmada. You remember from
Yes, sir, I know her, sir. I've heard about it, sir.
So you are almost replacing Dr. Narmada. So recalling the memory. Thank you. Thanks for all. God bless you. Thank you.
Thank you, sir. Thank you so much, sir. It's a very pleasure to hear from you.
Dr. Narmada.
Yes,
Dr. Narmada. Dr. Sushila here, madam.
Yes, ma'am.
I want a doubt about a child.
Yes, ma'am.
Suffering from atopic dermatitis.
Yes, ma'am.
She is 2.5 years old.
Okay, ma'am.
And she's got a patch on the right cheek with now developed a cellulitis. I put her on antibiotics to control the infection. About the cellulitis, can we use any anti-inflammatory? How do we manage this atopic dermatitis patch with cellulitis of the right face, madam?
Yes, madam. Atopic dermatitis is an allergic phenomenon, and you should know it is basically for the dry skin. Basically, you treat her now for the secondary infection with the oral antibiotics. If you feel it has gone, the inflammation is more. Or you can use topical
anti-inflammatory, madam. She is only 2.5 years old.
Anti-inflammatory we wouldn't use in atopic. The mainstay of treatment in atopic dermatitis is more moisturizing lotions, as well as hydration of the skin is our cornerstone of management.
I'm asked her to apply.
Yes, sir. Yes, madam. The cellulitis treated with the local, either with the local topical ointments or without steroid cream. And then you will also have to use for the if
anti-inflammatories are available.
It is not available, madam. It will not also basically
control the inflammation.
Inflammation is only with hydration and very careful use of steroids for the localized area in a short duration of treatments. And we should not use a potent steroid. We should use a low potent steroids on the face. So we have to be very careful if the lesion is very abnormal after treating the secondary infection.
Any low potency steroid which you can advise, madam?
Madam, I generally use the hydrocortisone ointments I use, or the Desanite gels which has come up with the Curaship company, that is a low potent cream which I use. But I will teach them that after the low application and everything, that is mandatory. And then a small tip, only very small tip of in their little finger, they have to use a very small amount of the ointment and apply it only.
One is the hydrocortisone, the other one, Desa? What you said, madam?
Desanite, madam. Desanite.
Desanite gel.
Yes, madam. Desanite gel. But in the face, I'm very careful about when I'm using.
Can you please spell it out?
DESONIDE. DESONIDE. And there was one repeated question, Subramaniam sir, about the adenoidectomy in children.
Yes.
Yes, so there are criteria, sir. That is why I got that video where I showed them the child was snoring with frothing. If this child has got snoring episode, we learn this scenario is an obstructive sleep apnea. It has gone in for an obstructive sleep apnea. Along with that, if the child is having recurrent ear effusions, middle ear effusions with the hearing abnormalities, which is found by tympanometry, if there's an evidence of middle ear effusion, then that is a direct indication for referral to an ENT and adenoid surgery. Otherwise, there are criteria like recurrent, how many times they have used antibiotics in the past 5 years and how many times they have used this year will help me out. So the involvement of the ear or the presence of an obstructive sleep apnea definitely pushes the scales up, and a referral to an ENT is always warranted. Always in a child who comes with an upper respiratory infection, ask about the snoring and look at the ear. If the ear has evidence of middle ear effusion, better get a referral to know whether they'll be indicated for admitted.
Sorry for the intervention. May I request our other delegate member, Dr. V. Nandagopal and Dr. M. Sinnasamy sir, you can join the interactive session along with our speakers and Dr. N. Subramanian sir. Sinnasamy sir, please. Yeah, proceed, madam.
Just one more last question from the chat box. How common is a premature aging in children, and any marker to detect it?
I have not seen in Mickey. I have not seen. No, but then I feel that, I mean, this is, I've not seen what their meaning is as progeria, which they see, but I have not seen in that till now. So probably students would deal better.
I have got two boys with that progeria.
Yes, sir, it's very abnormal. But what is really happening is children are, because of their dietary habit, they are getting premature graying of hair. Because they are getting into obesity. They are developing diabetes. It's more of a lifestyle diseases than the progeria which we are.
Premature graying is a fashion now for the girls. So
yeah, and after Tala's intervention, it has become a fashion.
Yes, correct. So with that little note, so I thank both the speakers, Dr. Makesh and Dr. Narmada, for a lovely talk. And the first half of our meeting for this year, I request Dr. Sudha Ramakrishnan ma'am for a vote of thanks. And any chairman's comments, sir, over to you. Thank you.
Yeah, we had a very nice discussion on the pediatric perspective of common clinical problems and geriatric perspective of the illness problems. Very nice. Thank you, Narmada ma'am and Magesh sir. We had a wonderful discussion on the common subject in the respiratory perspective: bronchopneumonia, asthma, reactive airway diseases, obstructive sleep apnea. So we had a very nice update. It will be very, very useful to all our members. Thank you, Narmada ma'am. Thank you, moderator sir, sir, for the wonderful moderation. So, Sinnasamy sir, any questions to your side, from your side? You can clarify and update, sir.
No question. It was all nice. Thank you.
Thank you. Can you see all my slides? Elite member, our Dr. N. Sudha Ramakrishnan ma'am from Trichy, Ojician. I request ma'am to give the vote of thanks, ma'am.
Thank you very much, sir. Good evening, good afternoon, everyone. On behalf of the IME NSB Academic Committee, it's my pleasure to deliver the vote of thanks. Firstly, I'd like to thank our President, Dr. Sandamil Pari sir, our Secretary, N.R. Tyagarajan sir, immediate past President Palnisamy sir, State Treasurer Alagu Venkateshan sir, for their good wishes, and special thanks to our President-elect Dr. Abul Hasan sir for his presence and kind words. So then I would like to thank our Chairman of our Academic Committee, Dr. Jayaraman sir, for crafting and conducting this program so very well. So the topics chosen were extremely fine, and also the speakers. Congratulations, sir. And my heartfelt thanks to both the speakers, Dr. Magesh, who spoke on the clinical perspectives of the geriatric age group. Thank you for reiterating the fact that we should maintain homeostasis and not go into homeostenosis. Thank you, sir. That was a very engaging talk. And I thank Dr. Narmada for the clinical insight into the problems of the pediatric age group over a variety of age. Your talk was excellent, and all your videos were very, very useful. Thank you, madam, for your wonderful talk. And I also sincerely thank the esteemed participants of the day. So without your presence, this program would not have been a successful one. So there were 100+ participants. That is a huge participation. Thank you all for your presence and your participation. You made a huge difference to this program. And I also thank our other academic committee members, Dr. Sushila Madam for the introduction, Dr. Rekha Madam for reciting the prayer, and Dr. Subramaniam Sir for the very smooth conduct of the program, and also Dr. Nandagopal and Dr. Chinnasamy Sir from our committee. I also thank the IT department and Mr. Aravind for the seamless conduct and relay of this first ever academic program of the year. Thank you all once again for your participation and have a good Sunday. Thank you.
Thank you very much, Sudha ma'am. We have a small announcement about the TNMC credit points. Those who wants the credit points, kindly enter your name, email ID, registration number, mobile number, and you have to pay by online in the you have to intimate to ima@gmail.com, our official state office email, and we are giving the online transaction to Indian Medical Association AMS, Academy of Medical Specialties. Account number already I put up in the chat box. Please note down. Any queries, please feel free to ask our members. The account number is 75260-10000-1890. Bank of Baroda, Theni branch. IFSC code BARB, BARB 0 THENIX, THENIX. So any query, please feel free to ask. So thank you very much for this wonderful academic virtual meeting. So thank you all for this joining here. I thank Chinnasamy Sir, Sudha ma'am, Subramaniam Sir, and all our Rekha ma'am, Sushila ma'am. So we had a wonderful meeting. So next month we have World International Oncology Day and Adolescent Day and all is coming. So I request our members to create a very good topic for our members to benefit, and we do the practical points for the ultimate aim for the people, patients cure and lessen the morbidity and mortality. With this aim, we have to approach this academic meeting every month, last Sunday, 10:30 to 12:30, 2 hours program with the CME credit points of the TNMSC. So I request everyone kindly coordinate and cooperate with these kind of meetings, update our knowledges. So thank you very much. Any queries, clarifications, please feel free to ask us, our members, myself, and our IMA TNSP office. So thank you very much for the wonderful. Have a nice day. Bye. Goodbye.
Thank you.
Thank you, Narmada ma'am. Thank you, Magesh sir. Thank you, madam.
Thank you so much for the opportunity, sir.
Nice, very nice, fantastic.
Thank you, sir.
So please note down the chat box. All the details are there about the TNMC credit points. Kindly go through. And within 3 days, you have to apply for the TNMC credit point through online transaction, ₹100. So we have to transfer the amount by online to Indian Medical Association, AMS, IFS code, everything is given. Any queries, please feel free to ask our state office or me or our members. Thank you very much. Bye. Goodbye. Thank you, Sudha ma'am. Thank you, Subramaniam sir. Thank you all for this wonderful gathering. Nice. We'll meet again.
Thank you, sir.